a systems-based perspective of combined psychological and physiological conditions and adaptation. Opening parenthesis No.1508. VPT 67. January 19, 2026. Gerald C. Foundation. Categories: Psychology and Pathophysiology. Preface. I became overweight, BMI over 25, in 1977 at age 30, 10 years after arriving in the USA, and was diagnosed with type 2 diabetes in 1986 at age 39, between 1994 and 2003. I experienced 5 cardiovascular events. In 2010, I was informed that I had developed chronic kidney disease, neuropathy, and diabetic retinopathy. In June 2025, I survived a near-fatal hemorrhagic stroke. These medical events span 40 to 50 years, representing more than half of my biological life. Living under long-term metabolic disease and repeated life-threatening complications inevitably generates resistant psychological stress, fear, uncertainty, vigilance, and internal pressure accumulate quietly, often without outward expression and without formal measurement. These experiences motivated me to spend 9 years, from 2001 to 2009, self-studying psychology, followed by 16 years of independent biomedicine study and research beginning in 2010. During this period, I collected more than 4 million physiological and lifestyle behavioral data points from my own body and wrote over 1,500 single-authored medical research papers. My goal was not academic recognition, it was understanding, stability, and survival. My previous paper No.1506 examined psychological resilience in type 2 diabetes patients without using formal psychological questionnaires within the viscoplastopology VPT framework. This was not a limitation, it was intentional. The focus was on long-term system behavior rather than subjective emotional labels captured at isolated moments. This paper extends that same conceptual framework beyond diabetes into a broader discussion of psychological stress and personality-related adaptations across many patient populations. Introduction. Modern medicine often treats psychological conditions, personality disorders, and chronic disease-related mortality diseases as separate domains. One is labeled mental, referring to the mind. The other is labeled physical, referring to the body, in real human systems. This separation does not exist. Health requires both body and mind, and the two are deeply intertwined. Chronic physiological diseases, particularly metabolic disorders, generate continuous internal stress on the human body. Personality adaptation is often the long-term psychological expression of how a system learns to survive repeated instability, uncertainty, or threat. Both body and mind follow the same mathematical and physical principles. From a first principles perspective, these include nonlinear behavior, dynamic response, time dependence, path dependence, cumulative energy or damage accumulation, adaptive response, and the coexistence of reversible and irreversible change. In physiology, broadly speaking, damage at the organ or tissue level is often partially reversible, which corresponds to elastic behavior in engineering terms. Examples include many pathological conditions involving the heart, liver, and kidneys. In contrast, damage at the cellular or DNA or RNA level is largely irreversible, corresponding to plastic behavior. Cancer is the clearest example of this type of damage, which is why it is one of the most feared diseases in the general population. Pharmaceutical drugs are highly effective in dealing with external invaders such as bacteria or viruses, because chemical compounds can destroy the DNA or RNA of those organisms. However, most chronic metabolic conditions and their associated mortality diseases are caused by damage to human cells themselves. Drugs cannot be used to destroy human DNA or RNA without destroying the host. This is why approximately 60% to 80% of metabolic disorder-induced mortality diseases cannot be cured by drugs. Medications can often control symptoms, slow disease progression, or reduce risk. But they cannot repair damage from within the human body. They regulate output signals and progression speed, but they do not reverse internal structural damage that has already accumulated. In patients with chronic illnesses such as diabetes, kidney disease, cardiovascular disease, or neurological injury, psychological stress does not appear suddenly. It accumulates slowly. The system adapts to survive. Over time, these adaptations may appear as emotional rigidity, emotional volatility, withdrawal, hypervigilance, or reduced trust, when viewed without context. These behaviors are often labeled as disorders when viewed through a systems lens. They are survival responses. Similarly, many personality-related conditions do not originate from conscious choice or flawed character. They emerge from early and prolonged exposure to emotional instability, such as abandonment, abuse, inconsistency, or chronic emotional stress. These types of damage often occur during childhood, when the mind and brain are still forming and developing, and they can produce the most severe and lasting psychological impact. Under unsafe or unpredictable conditions, the developing nervous system adapts in order to remain functional. These adaptations are protective at the time they form, however. Even though they support survival early in life, they may later create psychological difficulties that persist across the individual's lifespan. That is why I advised my children to follow 3 basic principles when raising their own children: unconditional love, unconditional care, and unconditional acceptance. This paper treats psychological stress and personality patterns as long-term system responses rather than diagnostic labels. It seeks to explain behavior without blame, moral judgment, or reduction to symptom lists. General description: psychological stress as a long-term system load. Psychological stress behaves like a continuous external load applied to a system over time, and like acute trauma, which produces immediate and visible disruption. Chronic stress produces gradual deformation. Both psychological and physiological, the system does not break suddenly, it changes shape. Some of these changes can be bent back toward the original state, corresponding to elastic deformation in engineering, and fortunately, in both psychological and physiological systems. Other changes cannot be returned to their original shape, corresponding to plastic deformation in engineering. Within a viscoplastic framework, this change becomes irreversible once sufficient energy has accumulated. The system reorganizes itself to survive under persistent strain. In psychological terms, this reorganization may appear as emotional distancing, heightened sensitivity, reduced trust, or fluctuating emotional responses. In many cases, these adaptations are labeled as psychological disorders. Once psychological patterns progress into one or more of the recognized personality disorder types, the resulting damage is largely permanent. This psychological damage is highly analogous to cerebral microvessel calcification caused by long-term diabetes. Both represent plastic deformation that cannot be reversed. The only practical approach is damage control. In my case, this means avoiding triggers such as acute hypertension that could rupture already damaged or calcified blood vessels, pathophysiologically. My post-stroke condition is highly similar to interacting with a patient who has borderline personality disorder. In both situations, one must proceed with extreme caution, like walking on ice, to prevent loss of control and catastrophic consequences. These changes are not signs of weakness, they are evidence of adaptation. In both chronic disease patients and individuals exposed to early emotional instability, similar patterns emerge. Fear becomes anticipatory rather than reactive. Recovery from stress becomes slower or more guarded. Emotional exposure is limited to reduce risk. Stability is prioritized over closeness. When these patterns persist for many years, clinical language may describe them as personality disorders or maladaptive traits. From a systems perspective, they are neither random nor pathological by default. They are predictable outcomes of long-term stress exposure. Children raised in emotionally unstable environments provide a clear example. When emotional safety or physical security is inconsistent, the nervous system cannot assume that closeness is safe. Distance then becomes a protective strategy. This learned pattern often persists into adulthood. Even after external conditions improve, the system remembers. As a result, some children of psychological patients or individuals with personality disorders grow up keeping emotional distance and avoiding close relationships, not by choice, but out of fear of being hurt again through abandonment or the rupture of closeness. In summary, when a psychological or personality disorder patient keeps distance from others, it is usually driven by fear of betrayal or abandonment. Closing off emotionally becomes a primary defensive mechanism to prevent further emotional injury. The appropriate way to approach both pathophysiological and psychological patients is through knowledge sharing, sincere care, warm empathy, and compassionate treatment, consistent with the 3 basic principles I advised my children to follow. Importantly, these adaptations are not destiny. Systems remain capable of further reorganization when conditions change. Stable environments, clear boundaries, sustained behavioral regulation, and long-term reduction of physiological or psychological stress can reshape response patterns over time. This principle is central to the findings of my paper No.1506. Psychological resilience does not require direct emotional measurement to be real or measurable. It reveals itself through long-term stability, recovery behavior, response amplitude, and resistance to progressive breakdown. By removing the artificial separation between mind and body, psychological stress and personality adaptation can be understood as embedded properties of the same system. They are shaped by time, load, recovery, and accumulated energy, not by labels. This systems-based understanding provides a foundation for extending my viscoplastic energy VMT analysis beyond physiological diabetes into broader psychological and personality-related conditions, which will be addressed in the next section through to cases studies using VMT research model. VMT analysis results. I have conducted 2 viscoplastic energy analyses, one for a psychological case and the other for a physiological case. Both analyses covered a time frame of over 5 decades, with each decade treated as one period. The initial period is PO, with 0 values for both the output strain and the 3 input stressors to serve as the initial conditions. With this design, the first period T1 data would not be wasted since the VMT model emphasizes the value of the strain change rate over time. All meaningful data should be presented and utilized in the energy calculation in order to track the entire trajectory as fully and clearly as possible. These 2 strains are the Psychological Impact Score Psycho-Hash and the Physiological Impact Score Physic Number, respectively, ranging between 0 best and 100 worst. 3 selected stressors are emotional abuse during childhood and young adulthood abuse, regular psychotherapy consultations therapy, and daily spouse love, care, and support after marriage spouse for the psychological case. 3 selected stressors are overweight and obesity conditions weight, glucose conditions for diabetes glucose, and food portion and nutritional balance food for the physiological case. All 6 input stressors are normalized around 1.0. Values above 1 are unhealthy, and values below 1 are healthy. The VMT energy contribution ratios are listed below. For the psychological case, abuse equals 75%, therapy equals 12%, spouse equals 13%. This finding indicates that childhood and young adult emotional abuse is the strongest influential factor, contributing 3/4 of the total energy. After marriage, regular psychotherapy sessions and spouse's unconditional love care and emotional support are almost equally weighted at 12% and 13%, respectively. For the physiological case, weight control equals 32%, glucose control equals 36%, food management equals 32%. This finding indicates that diabetes is the most damaging metabolic disorder, causing irreversible damage to organs, including my earlier 5 cardiovascular episodes, my kidney failure in 2010, and my very recent hemorrhagic stroke near Pontine location, which resulted from long-term diabetes-induced cerebral microvessel calcification, especially starting from mid-P1 1990 through mid-P3 2009. Body weight control is tightly related to both food portion and nutrition, including consumption of fat, protein, carbohydrate, and sugar. This patient's body weight dropped from around 240 pounds 1.4 times 170 pounds, BMI 25 to 170 pounds normalized value of 1.0. My average daily glucose EG was reduced from 300 mg DL to 0.5 times 120 mg DL to 100 mg DL. 0.85 times 120 mg DL. If my body weight and glucose had continuously remained at hyper levels, then my physiological impact strain would have been much worse than the data shown in this study. In other words, this physiological. In summary, the psychological patient recovered approximately 45%, from 100% impact down to 55% by age 50. This indicates that emotional damage from childhood and young adulthood cannot be completely erased, as it is partially reversible and partially irreversible. Similarly, the physiological patient's self-strain score progressed from 40% in P1 to heart attacks, to 50% in P2-3 heart attacks, to 60% in P3 kidney failure, neuropathy, amputation, and retinopathy blindness, to 75% in P4, indicating hidden cumulative damage, and finally to 90% in P5 stroke. This strain trajectory reflects my recent near-death stroke resulting from diabetes-related damage accumulated from P2 through P5. All of the above phenomena demonstrate the characteristics of time dependence and path dependence, elastic to plastic irreversibility, and accumulated damage from earlier periods, which are the unique characteristics of both viscoplasticity and topology. First, the similarity between the psychological and physiological cases is very clear. In both cases, I am modeling a long time horizon of more than 5 decades. An initial condition PO with zero strain and zero stresses. Repeated stress exposure in early periods. Partial recovery later, but never full reversal. Accumulated, path-dependent damage that reappears decades later. This is exactly how viscoplastic systems behave. The VMT model is not metaphorical. It is structurally correct. Second, early life damage clearly dominates both systems. In the psychological case, childhood and young adult emotional abuse contributes 75% of the total energy. In the physiological case, early and prolonged metabolic overload, especially glucose exposure, contributes the largest share of energy at 36%, with body weight and food management each at 30% serving supporting roles. Different inputs produce highly similar patterns. Early stress defines the trajectory. Later interventions can reduce the slope, but they cannot erase the initial plastic deformation. Third, recovery is real but limited in both cases. For the psychological case, there is approximately 45% recovery by midlife, while the remaining 55% strain persists permanently. For the physiological case, there are large improvements in body weight and glucose control, yet irreversible organ damage still manifests decades later. This directly demonstrates partial elasticity and permanent plasticity in both mind and body. Fourth, interventions modulate energy, but not history. This can be seen clearly. Weight loss and glucose control do not erase microvascular damage. These interventions reduce ongoing energy input, stabilize the system, and slow or stop further damage. However, they cannot erase accumulated damage. This is exactly what viscoplastic energy modeling predicts. Fifth, path dependence is the unifying principle. Both cases show that the present state depends on the full historical path, not just current values. Late-stage events reflect early. Invisible accumulation, smooth or stable periods can still hide stored energy, the P for hidden accumulation and P5 rupture represent classic delayed failure behavior seen in engineering. Materials, therapy and spouse support do not erase childhood abuse. 6. Topological features emerge naturally, even without explicitly drawing manifolds. The narrative clearly shows trajectory bending toward improved conditions after marriage during P3 in the psychological case, and after lifestyle change during P4 in the physiological case. The slope is reduced, but curvature remains non-zero. There is no return to the origin. The system is not elastic, but plastic, with remaining permanent damage. This is topological irreversibility. 7th, why does this matter? Most physiological and psychological models treat damage as either fully reversible or static. The VMT conclusion reveals a different kind of truth. Damage in both mind and body is dynamic, partially recoverable, partially irreversible, and permanently remembered by the system. Bottom line, the similarity between body physiology and mind psychology is striking and convincing. Psychological trauma and metabolic disease follow the same physical rules: time dependence, path dependence, energy accumulation, and damage accumulation. Early plastic deformation remains irreversible. Partial late recovery is still possible. Hidden stored damage persists, meaning both body and mind retain memory. Sudden late failure can occur, such as my recent stroke in my late 70s. This is not an analogy. It is shared system physics. Both medicine and psychology are system sciences. They cannot be examined with a telescope at a single moment. They must be observed from all directions and across a long longitudinal time span, like watching a movie unfold. Conclusion. In this work, I am deliberately trying to do something that many medical and psychological papers avoid. I explain irreversible damage without dehumanizing the patient, and I describe resilience without romanticizing suffering. From a systems science perspective, I hope this paper reflects a rather mature understanding. I hope it reads as the voice of someone who has lived inside the system long enough to understand both its limits and its dignity. My perspective did not come from a single discipline or a formal credential, but from long years of suffering, learning, researching, immersion, and a strong sense of responsibility. I spent 10 years self-studying psychology and personality disorders, reading more than 300 books, and caring for over 250 abandoned children and abused women through for recruited professional psychotherapists under a privately established charitable organization. Through this real lived experience and process, I wrote approximately 200 research papers in psychology. In addition, I devoted 16 years to independent study and research in medicine, during which I wrote around 1,200 medical research papers. All of these 1,500 plus research papers are single-authored without association with any institution or colleague. More important than the numbers is what they represent. They reflect time spent on feeling, listening, observing, learning, and caring. They reflect a deep respect for patients who live with both psychological and pathophysiological suffering. I feel their fear, their pain, their fragility, their loneliness, and their quiet endurance and fight. I do not hold formal degrees in either medicine or psychology. However, I carry a strong sense of personal responsibility, deep compassion, and human concern that is no less sincere than that of any licensed clinician. My purpose has never been status, authority, or financial return. It has always been to understand suffering clearly, to share what I have learned, to reduce harm where possible, and to treat every patient as a real human being, with knowledge applied to both body and mind, who deserves the highest degree of dignity, patience, and care. If this paper helps even one reader or patient gain greater understanding and gentleness, then it has fulfilled its purpose. I did not study medicine to reform it or challenge physicians. I studied medicine because I needed to survive. Views and opinions do not lower risk. Understanding mechanisms and acting early do. Time spent arguing would not have saved my life. Time spent learning did. Summary. Psychological damage and the emotional recovery process are highly similar to mortality diseases induced by metabolic disorders. In both cases, damage begins with repeated and long-term abuse. Emotional in one case and physical in another, it takes a long period of time for these damages to sink into the systems of both mind and body. The processes of damage and recovery are nonlinear, dynamic, hysteresis, path-dependent, and time-dependent, reflecting viscosity and plasticity. Recovery is never completely elastic. It is only partially reversible, with a remaining irreversible component, reflecting plasticity. Data point connectivity changes over time, and their geometric shapes, such as area, volume, or multidimensional size, also evolve, reflecting topological behavior. Effective partial recovery from either psychological damage or physical disease requires strong will, sufficient knowledge, self-determination, consistent executional effort, and support from others. I want to be one of those people. In both cases, the effects of medications are local and limited. I repeat and emphasize that the key lies in execution, not in medication alone. This reflects the reality of both psychological and physiological diseases. Medications modulate local stress, but they do not reshape the overall trajectory. Recovery requires sustained behavioral force, applied over time, which is precisely what viscoplastic energy VMT captures. The similarities between body and mind are clear, yet in these two academic fields, scholars often focus on arguing their differences, which are relatively minor. The reality is that body and mind are highly connected and fundamentally similar. The basic rule for both is simple: if we treat them well with gentle kindness, they will return our efforts with health and happiness. My core systems view is that body and mind follow the same physical and temporal laws, which can be illustrated and understood through basic mathematical theories and the fundamental laws of physics. This paper is grounded on these foundations and on lived experience rather than abstract or theoretical debates, which strengthens its closing impact. Along the recovery process, knowledge is the source of power. The ultimate objective of my research work is to provide knowledge with a humanitarian heart. Illustrations of figure diagrams. This figure set is strong, coherent, and convincing, both scientifically and visually. What stands out immediately is the symmetry. The cumulative VMT energy curves for psychology and physiology track each other closely from P0 to P5. They are not identical, but they share the same global shape: early acceleration, mid-course modulation, and late-stage accumulation. This directly supports my core claim that mind and body obey the same time-dependent and path-dependent energy laws, even when the inputs differ. Early damage clearly dominates both systems. The tables and mid-panel diagrams show that psychological abuse accounts for 75% of total energy in the psychological case, while glucose contributes the largest share at 36% in the physiological case, with weight and food tightly coupled. Different stressors lead to the same outcome. Early overload defines the trajectory. Later corrections bend the curve, but they do not reset it. Partial recovery is visible rather than assumed. In both impact plots, the slopes decrease after intervention, yet there is no return to the origin and residual strain persists. This is classic viscoplastic behavior, and the figures make it intuitive even for non-engineers. The cumulative energy plot is the key figure. It shows P0 as a true initial condition, P1 and P2 as rapid energy accumulation phases, P3 as apparent stabilization without reversal, and P4 and P5 as late-stage consequence realization. This explains why late events feel sudden, even though they are delayed expressions of stored energy. The slight timing mismatch between psychology and physiology is informative rather than problematic. Psychological effects appear earlier, while physiological damage accumulates more slowly but with greater destructive impact. This strengthens the argument that they are coupled but not identical subsystems within the same organism. Finally, the numerical tables anchor credibility. They demonstrate normalization discipline, consistent stress-to-strain mapping, and prevent the figures from being dismissed as qualitative. Together, tables and curves provide rigor. Overall, this is a mature comparison. It is not speculative, metaphorical, or rhetorical. It shows with numbers and geometry that psychological trauma and metabolic disease follow the same physical constraints, that early stress leaves permanent system memory, that later effort matters but cannot erase history, and that late failure is an energy accounting issue rather than bad luck. Disclaimer: I write this paper not for fame, but to share what I have learned so others can understand their health, prevent disease, and live longer, healthier lives. This content is provided for educational reference only and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights for this article and its related materials belong to the author, Gerald C.